I do want to thank you for having me today, because I do think this is an incredibly dynamic time in healthcare in general, of course, but particularly for public hospital systems. And the set of issues I'm going to talk about today are really things that CAPH itself is wrestling with, and I'll look forward to your questions and some of the discussion after my presentation and Dr. Katz's presentation. If history is any guide, when major health reform efforts have failed, what they turn around and do is cut deeply, very deeply. And I would argue that the only way for public hospital systems to potentially sustain those kinds of cuts, if they unfortunately come to pass, because there are major threats to health reform or an undermining of health reform in some significant way, the only way public hospital systems can survive that is if we prepare as if reform is happening now anyway, and work on those very same issues of quality, cost, better results for the dollars that we're spending in healthcare. So I don't think it matters at some level. I mean, I wouldn't want this to be quoted out of context, but it doesn't matter at some level if something changes with reform in terms of the politics or the Supreme Court or anything else. We have to make these changes in healthcare anyway. I do think that passion for the mission makes a difference, and we need to keep that front and center and incorporate it into our work. And at the same time, the challenge is the passion for the mission isn't enough anymore. You know, there was a time when CAPH could go to Sacramento or Washington, D.C. and say, hey, public hospital systems need more money and more support and this and that because we're doing God's work and it's really important and we're serving low-income people and they need health care too, and it is critical that we do that. It's the right thing to do. We must do it. You must support us. And there was a time and a place where that worked and it was effective and it succeeded. But I need to let you know that not for lack of trying, but that is no longer effective in and of itself. If we can say that, plus here's our performance, here's our value, here's the difference we make for our patients and for our communities and the quality we deliver, and look at our diabetic patients and the outcomes they're having now versus before. Look how many people are in an appropriate and effective medical home. Look at what we can do to reduce readmissions. Look at our patient experience scores and how they're going up. Look at how we've reduced all of these hospital-acquired conditions and infections. That is what needs to lead us forward, and the money can follow. We have dealt with limited resources and great challenges for our entire history. And we are in that place again. And I think we can take that experience to really embrace the transformation agenda and challenge that's ahead of us and work that through. And I do think that means we have to be bold.
DHS has been a system that has traditionally been dominated by its hospitals. So to me, this is fantastic. This is the moment when all of the financing changes and we get to do the right thing. We get to focus our resources where the people that we serve most want them, in their community, in settings that are much safer for them and better for them than the hospital. And then we also, in that way, disimpact the hospital such that when people need emergency care, when they're in that accident, when they need surgery, they get it promptly because the hospital is not filled with people who are waiting to be discharged to a lower level of care. So why am I optimistic? Well, I look at the last 14 months and what we've done, right? We've been able to impanel through ambulatory care, just counting our own facilities, so not counting the community partners, 240,000 patients. That's amazing that we were able for the first time to say to people, you know, this is who your doctor, nurse practitioner, this is your clinician. Also in ambulatory, we've been able to increase the number of primary care slots. I know that's been a huge issue. We want more primary care. Money is tight, as Melissa was saying. It's unlikely that we're going to get a great deal more money. So what did you all do? You produced the equivalent of 2 health centers worth of primary care appointments just by asking moving administrative responsibilities away from some of our clinicians to other administrators so that the clinicians could spend more time doing actual clinical work. And we moved people from working in walk-in type settings, urgent care settings, to actually being able to take care of people in primary care. What is not a very efficient use of urgent care walk-in is the person who is in their 50s, knows that they have diabetes and hypertension and heart disease, and doesn't have a regular doctor. And they don't have a regular doctor because our system hasn't had enough primary care access. Right? We are a system in some ways that mirrors the American healthcare system, which is too much specialty relative to the amount of primary care. Now, I know you say, well, but that's a surprising statement because we hear so much about the specialty access delays. But you see, that's related also to primary care. When you don't have enough primary care, then the specialists can't just serve as consultants. They're actually taking care of patients in an ongoing way. And that's why when you all did the look at the specialty decompression, you found so many people who could leave specialty care, right? And they could go to primary care, right? Because the specialists are busy, but they're busy seeing many of the people who could be seen in primary care. Meanwhile, urgent care is busy, but they're seeing people who should be in primary care, often with the same people who could be doing primary care practices. So the fact that we need to reorient ourselves, that we need to focus on a different model of care, I think that's fantastic. The other things we have in favor is that in our hospitals, the quality of the care that people are getting is as good as they would get anywhere. I'm convinced of that from working on the wards here at LAC-USC, from being part of the governing body and reviewing records of Harbor and Rancho and Olivine. What is not as good as what people would get is patient experience. Our quality indicators, if by quality we mean the quality of our physician staff, our nursing staff, that's terrific. What is not terrific is the wait times. And by waits, I don't mean that you have to wait 6 weeks for, say, a specialty appointment. I mean you arrive at clinic at 9 o'clock and you're seen at 1 p.m. See, I can accept the first one, right? Even the private sector, people with private insurance will have to wait 6 weeks. And many things can wait 6 weeks or 8 weeks or 12 weeks, especially if you have a good primary care provider. What I can accept is that if we give somebody a 9 o'clock appointment and we see them at 1 o'clock, that's wrong. That's just wrong. Because you can't argue that's because we're busy, right? Because you are seeing them. It doesn't take any longer to see them at 9 o'clock than 1 o'clock. It's just that we haven't oriented our systems so that when we give them that 9 o'clock appointment, we know it really means 9 o'clock. I believe that the right thing always wins. That you just have to be committed to what is the right thing. And that for all of the complications of these healthcare laws and ACA and ACO and what does it all mean, what I keep thinking about is, what does the patient need? Let's just forget for a second about the ACO and the different ways of paying, because you could drive yourself crazy trying to track that. Right? It's so much easier to think about the people that we actually see. And what is it that they need? Right? They need care that is thoughtful, that really is compassionate, that uses all of us as healers in a meaningful way. They need that care to be accessible where they are. They need not to have to wait ridiculous periods of time to get it, or they will choose other providers, and you know what? They won't get as good medical or nursing care. I want to end with sort of a little bit about sort of how we extend ourselves, because I do think it's a little bit about extension. So one of the things that's important to me is that people who are working at every level of our organization are constantly thinking about how they extend themselves to take care of the people we take care of. And there have been some really positive examples, and I want to note them. So like Irene, I said to Irene when we were talking about nurse breaks, I said, Irene, why can't the supervisory nurses fill in for the lunch breaks? I mean, it's a portion of the day. They're about to come and put you in handcuffs because you're about to get your 4th citation for failing to cover, your nurse breaks, which is the law. We're working on increasing your staffing, and we are. Irene has gotten some of it. But I don't know that we're going to ever get to it. How about asking your nurse managers? And Irene thought about it, and she did it. And one of the things that she told me was that the staff were incredibly grateful that the nurse managers were helping. And that it resulted in the staff nurses looking at the nurse managers in a different way.